Hi, everybody. My name is Sunil Varghese. We're just going to give it another minute or so to give an opportunity for people to log on for today's discussion. Okay, it's 12:01 by my clock, so we'll get started. I'd like to welcome everybody for attending today's Lunch and Learn webinar. Today it's titled PPE 101, Lessons Learned from a COVID-19 Unit. And just as a bit of context, since the COVID pandemic started, we as a regional association have been putting out webinars for COVID-related updates. We started this in about April, May, and this is our 6th or 7th one. Regarding this. We haven't had one related to COVID for the last couple of months, but now with the upswing of cases that are occurring in the region, we thought it would be a good time to again bring these issues to the fore. So this is our first of the rebranded version of these talks. And today's is a lunch and learn specifically catered to what is happening on the COVID unit. And I'm very pleased to welcome Dr. Ruchi Murthy, who's a infectious disease physician at the Queensway Carleton Hospital, and Nurse Jennifer Dale Tam, who is the nurse educator at the Ottawa Hospital COVID unit. She'll give you a little bit of details about that at the Civic Campus. And my name is Sunil Varghese. I will serve as your moderator today. I'm the chief of the Department of Medicine at the Queensway Carleton Hospital and chair the regional committee that is putting these on. So, before we begin, just a couple housekeeping items, if I may. The first and foremost is that we'd like to keep this interactive. So you will see a chat function on your screens. Unfortunately, with the way that this is organized, we can't actually have live discussion, but please enter any questions into the chat function. I will see them and we will relay them to the presenters who can answer them roughly in real time. Secondly, there will be a recording of this webinar available. It'll be up on the academic site in about a week or so, and we'll get a notification for that. You'll receive a notification for that. Okay, with those two caveats, without further ado, let me turn it over to Dr. Murthy to begin her part of the presentation.
Okay, thank you very much. I'm just going to get my slides up for everyone, and I'll just have you, Sunny, confirm that you can see them. Can you see the full screen slides?
Nope, they're coming up not as full screen, but we can see the slides.
Okay, just give it 1 second. Let me see if this will make a difference. How about now? Is that full screen?
No, but we can see the slides pretty clear.
Okay, I'll just continue then, and if I can figure out how to do it, I will. Otherwise, I'll just start chatting since we're live. So happy lunch, everyone. I'm Ruchi Murthy with Infectious Disease at the Queensway, and I'm just going to go through a few updates surrounding COVID-19 as it pertains to all of us healthcare workers. We'll do a quick overview, talk about infection characteristics, and discuss the transmission characteristics, which I think really are important to most healthcare workers in the current environment and with the upswing of cases, and just briefly touch on some treatments. For the sake of this talk, I'll be using the term COVID-19 to refer to SARS-CoV-2, which is the name of the virus. So let's get started. So coronaviruses, or the Coronaviridae family of viruses, are non-segmented positive sense RNA viruses. They're part of the coronavirus family, which are widely distributed. And prior to the fame that COVID-19 has brought, they were most commonly known to cause the common cold. Coronavirus the term corona refers to the spikes that are noted on electron microscopy, which is what this picture is representing here for you today. They're supposed to represent the spokes of a crown. So that's where the word corona comes from, not the beer. Viral entry, or how the virus actually infects cells, is hypothesized to work through this ACE2 receptor, which is found on the lungs at the area of blood and oxygen exchange, which is at the level of the alveoli. This is why we see most of the infectious manifestations at the lung, but what we're learning is that these receptors actually exist on many different organs in many different parts of the body. This will end up becoming very important in the future as therapeutics are explored and we try to figure out where we can stop this virus from entering cells and wreaking the havoc that it does. Just to give you a brief overview of pathophysiology, this is an image from one of the Lancet articles talking about coronavirus. The uniqueness of SARS-CoV-19 is how it manifests in these different stages of illness, from barely any symptoms at all to severe shock, severe lung damage, and requirements for intensive care ICU. And so the understanding of this infection is that when it first starts off, people are generally very mildly unwell, maybe have a touch of fever, dry cough. And as the virus sort of enters the body, the immune response starts to wake up and react to it, which is why people become sicker with a bit of time. That's why in this model that I've shown here, that's represented by the pulmonary phase, where we start to really see side effects of that lung damage from the infection. Things kind of go out of control in stage 3 with your immune response as your body starts to overreact to the exposure to this virus, and this is when people get critically unwell. What this means for you practically when you're seeing your patients are that there could be people that are asymptomatic or pre-symptomatic, meaning they have a positive COVID test but no symptoms, all the way down to being critically unwell, where they require oxygen support in the ICU or septic shock, and multiple organs are not working well because of how aggressive the body's immune reaction is to this infection. Again, we're discussing updates today, so I thought it would be important to flag that the CDC recently updated their list of risk factors to COVID-19. Previously, the top risk factors were considered to be obesity, high blood pressure, diabetes, to name a few. And now that list is expanding as we're learning more and more about this type of infection. And so the ones that are listed at the top of this long list include multiple conditions that could be responsible or risk factors for severe illness.
Ruchi, sorry. Yeah. Sorry to interrupt, but I'm not sure if you're moving your slides and if it's just being stuck. We're still seeing the title page.
Oh my goodness. Okay, let's see if this makes a difference.
Just scrolling down, it helped. We're seeing the different slides now.
Is that helpful to you?
Yep, that's great. Thanks. Sorry
about that. So you missed my cool animations, but there's the crowns. And this is the pathophysiology that I was referring to. I hope that gives you a bit of a visual. And here's our overview as well, talking about asymptomatic to critical illness. And this is a long list of risk factors, which I wanted to flag to your attention. So let's get to the meat of this. And so the question that I think is relevant to all of us is how infectious truly is COVID-19, and what does this mean for us on a population level and on a personal level as healthcare workers who are around COVID patients. R0 is a number that you may have heard of in the media, which is a statistical number that we look at to see how many other cases come out of one exposed case. So in other words, the average number of secondary transmissions from one infection. Whenever that number is over 1, that means that the epidemic is growing. And so, for example, influenza from 1918, the R0 was 2. For every one case, there were 2 cases that got produced. The estimates for the R0 from IPAC Canada are 2.5, and this is what we saw in China as well. Keep in mind, though, that is reflective of the virus without any interventions and without any other factors to influence the infection itself. What actually becomes more helpful is the RT, which looks at how many cases are infected from one case in real time. Right now, when looking at the public health website, our RT in Ottawa is less than 1, which is a good thing. That means that there's less than 1 case getting infected for every case that exists. So that'll hopefully bring the cases in the community down in terms of numbers. This is what we understand about the infectious nature of the infection on a population level. But what it really boils down to for most of us is the transmission. And the bottom line is that we get this infection from other people. It's a person-to-person spread. That's why when we are talking about what our risk of exposures are, it's most commonly close range droplets with contact with mucous membranes, so your eyes, your mouth. Touching of infected surfaces and then touching these mucous membranes can also lead to possible infection. And what's more controversial is airborne transmission. I'm going to try to debunk some of these concepts for you and give you a bit of the evidence as to why we do what we do. I was also, when putting these slides together, wanting to answer this question for all of us, which is what really boils down to us on a personal and professional level of, what do you do if you're exposed? What are your odds of becoming infected? And the answer is not easy to this question because it depends on so many different factors. To put it blatantly out there, there is risk to healthcare workers, which I think we all need to be aware of and appreciate. Public Health Ontario looked at 48 different case studies in August of this year to compare the risk to healthcare workers compared to others, and there's certainly increased risk. Again, these studies have biases, there's a lot of confounding factors, but there is something to be said for the fact that healthcare workers do experience more risk. The factors that they've boiled it down to include improper use of PPE, unrecognized sources of infection in patients and colleagues, which is why we're being so vigilant in healthcare settings now by trying to keep protected in all settings. As well as family exposures. We all have more than one life. We're not just in the hospital, we're also at home. And so it's important to recognize that that's also a risk for infection. Now, speaking of home, I thought this was a really important concept to take away. It was looking at household attack rate, meaning if someone in your house is sick, what are the odds of you getting sick? And so the most recent evidence surrounding this came out 3 days ago, looking at the household attack rate for SARS-CoV-2, and found that the secondary attack rate was about 17%, and other studies show the same thing. What's interesting, though, is that for people less than 18 years old, we've seen in other studies that attack rate is probably a little bit lower, and for partners of the index case, the attack rate might be a little bit higher. So the average risk is probably somewhere around 17% in your home where you're not going to be using PPE, physical distancing, or other strategies to really isolate yourself. This is probably one of the reasons why we saw such increased numbers in China, and there was quite a bit of household attack rate noted back then as well. So something to be mindful of in the home environment outside of work as well. Now, in regards to nosocomial transmission, meaning transmission of infection in a healthcare setting, there have been a few studies that have come out which are, I'd have to say, rather reassuring. For example, one of the early studies that came out of China from Wuhan, from one of the original, in Hong Kong, back in April, demonstrated the risk of nosocomial transmission was very, very low in this one case where they had one patient who was exposed to many people and even had intubation, which is considered a higher risk procedure now, which did not lead to any secondary infections, even with droplet and contact precautions being used alone. This is without the use of N95s. More recently, there was a large study done in the States, which was just published in September, which looked at almost 700 COVID-19 positive cases. And in relationship to these 697 people, there were only 2 hospital-acquired cases that were detected, which couldn't even really be attributed to the hospital experience itself. All of this to show that in-hospital transmission of infection to other patients seems to be fairly well controlled with appropriate PPE. There's been questions about aerosol transmission of COVID-19, and the evidence surrounding this is not robust, which is why it remains very controversial. Early on in the pandemic, there was this study done where they took these military-grade jet nebulizers to try to blast the particles up into the air. And when they did that in these very inorganic settings, if you will, they were able to get virus into the air for anywhere from 3 to 16 hours. And so this study showed that COVID can be aerosolized, but when thinking about it practically, this is not really reflective of normal human cough conditions. And so, yes, in this type of environment where there might be aggressive aerosolization, there might be validity in using N95 masks, but not in normal human interactions. Other evidence to support why transmission is unlikely to be aerosol is looking at airplane medicine and how we're not really seeing transmission of COVID through airplanes. And keeping in mind just about how viruses work in nature, the secondary attack rates for other viral infections that are actually airborne are much, much, much higher than 17%. In fact, measles is documented over 90%. So it doesn't quite add up. So to put it into blunt and blatant terms, droplet and contact precautions are appropriate measures to protect us from acquiring COVID-19. Airborne precautions, meaning escalating your PPE to include an N95 mask, should be considered for aerosol generating medical procedures. And of course, it's incredibly important to comment on hand hygiene very quickly. Just this week, a study came up from Australia looking at the ability of the virus to survive on surfaces. Again, this was all very experimental, so not used in real life, but important to note that it's very important to wash your hands because there's a chance that virus can still enter your mucous membranes, your eyes, or your face if you're touching a contaminated surface. For the interest of time, I'll just skim through the treatments very quickly. Essentially, still supportive care is the primary means of treatment for the vast majority of patients. The drugs that you may have heard of in the news include remdesivir, which is an antiviral medication, was previously studied for the treatment of Ebola, and more recently we're starting to learn more and more about it. Recently, it's been approved from Health Canada for specific populations of people. We'll probably be learning more about it in the weeks and months to come. But essentially right now, for people that require a little bit of oxygen, they might get better faster if they take this medication. We don't know if it'll change mortality, but there could be some benefit there. And the other drug that you may have heard of in the news is something called dexamethasone, which is a strong steroid, which is actually starting to show some evidence that it might have lower mortality risk. So it's being used very frequently, at least now at the Queens by Carleton, for some of our COVID patients. There are other treatments that you would have heard of potentially in the news. Hydroxychloroquine's been very heavily discussed in the media. This has been debunked. There has not been any mortality benefit proven, and in fact, there's been noted risk of toxicity. So that's really off the table right now. But there's a lot of scientific research going on into other tools. I know that was quick, but I just wanted to summarize by saying this is still an ongoing challenge. We're learning things every day. Transmission, even though I've discussed other possible modalities, is primarily droplet and contact, and PPEs still incredibly important to minimizing your risk of exposure and decreasing the transmission of the virus. Let's just keep up the good work, everybody, and go ahead with your questions in the chat if you have any.
Great, thank you, Ruchi.
No problem.
So as Ruchi mentioned,
yeah.
As Ruchi mentioned, if there are any questions in the chat, if you have any questions, please add them to the chat. For now, what we'll do is we'll move to Jennifer, who, as I mentioned before, is a nurse educator and leads the COVID unit at the Civic Campus of the Ottawa Hospital. Jennifer, can I turn it over to you?
Yeah, absolutely. Can you hear me?
It's great.
Okay. Hi, everyone. I'm just going to share my screen just to ensure that we're all seeing the same thing. And I want to put it on this one. Can you guys see my screen?
Yep.
Perfect. All right, so my name is Jennifer Dale Tam. I'm a nurse educator at the Ottawa Hospital. My inpatient environment area is the general surgery unit and the COVID unit at the Civic Campus. I also have a couple ambulatory or 5 ambulatory care clinics that I look after, and I do some work with TOH education with some simulation stuff and other components. My presentation today is going to be on sharing a bit of the lived experience that we have from our particular inpatient COVID unit. And from that, we're going to share a bit of our tips and tricks regarding daily care and workflows when looking after COVID-19 patients. So just to provide a little bit of context, the Ottawa Hospital, as most of us know, is situated in Ottawa. We do have 2 campuses. We've got the Civic and the General, and each campus does have its own COVID unit. When we started at the beginning of the pandemic, we started with 2 36-bed inpatient units. Now, this is not the critical care area. It's where the regular inpatients go. We started with a full complement of 36. We didn't fill up completely, but over the course of 3 months, we went back to about 2/3 being surgery and 1/3 being COVID. So here at the Civic campus, that's located on B2, and over at the General campus is located on 6 Northwest. Each unit has 12 beds, and we have a fairly robust turnaround time on it. So I'm going to be sharing my particular, or the experience of our unit, but there's a lot of commonality that's been happened over at the General as well. So some things that we have found is use of environmental cues, because this can be an area that's very stressful for nursing staff, especially if you're new to it. So having appropriate room signage versus having contact and droplet or aerosol droplet precautions, depending if you have an aerosol generating medical procedure with it. I have found over time, we did a lot of education sort of at the beginning related to aerosol generating medical procedures for my nursing staff. And over time, things kind of get forgotten. So when things switch between being non-aerosol to aerosol generating, staff kind of forget that part. So what we've done, particularly in our unit, is actually posted the common aerosol generating medical procedures that they're actually seen on our unit, just so that the nursing staff know when they need to flip between droplet and contact versus aerosol droplet contact. We've also posted the PPE donning and doffing checklists. I've got that on all of our PPE carts, plus also at the entry to every single room that has a COVID patient in it. We're lucky at this campus, the way that our infrastructure is kind of in place, we're actually able to have a closed unit that has separate doors, so we don't have any through traffic or things that go on with that. So it's nice to be sort of isolated from that part. One thing that comes out a lot in sort of the literature is the use of what we call yellow, red, green areas. We didn't have the capability to necessarily mark them off where you could actually see the visualization, but when we were talking about yellow, red, green areas, we talked about it more through socialization. So just to kind of break that down a little bit, red is considered a hot zone. So this is where you have a higher exposure rate or possibility of seeing a patient that has COVID, or a patient being exposed to COVID-19. So this would be areas like the patient rooms. Yellow or orange areas are not necessarily sort of the care area, but it's more the hallway or the nursing station that's related specifically to the COVID wing. And then our green is where there's a low risk area. So we kind of talked about this every day when we were doing sort of our huddles, and the staff kind of have that in their reference for their context. So the use of environmental cues has actually helped quite a bit. When we talk about sort of the care of a COVID-19 patient, whether it be suspect or confirmed, one thing that with nursing staff, especially as we trained, or allied healthcare professionals, sometimes we've taught to try and spread out our care, just not to stress our patients. But with this particular one, you want to cluster as much of your care as possible, because you're going to be going in and out of the room, use of PPE, decreasing sort of your risk of exposure. So clustering as much care as possible in that particular session. You want to prepare as much as your medications, any equipment or anything that you might be taking into the room, have it all outside the room for you before you go in. You want to limit the actual equipment that goes into the room, because anything that goes in is going to be considered contaminated, and preferably not bringing it out. So one thing that the Ottawa Hospital did specific to our meal trays is they've actually gone to a completely disposable model for our meal trays, so that when the meal tray goes in, it gets disposed of in the garbage instead of having to bring the tray out. On our regular inpatient environments, we have meal trays that are brought back out. The use of a runner, this is really helpful, especially if you have someone who's in an aerosol generating room who can go and get supplies for something that may be forgotten. So that healthcare provider doesn't necessarily have to doff and then go and get what they need and don their PPE again. They just have someone hand it to them. Not always possible. It can be challenging, especially with the staffing times, but if you can have someone who can function as a runner, and it doesn't necessarily have to be an RN, it could be a volunteer, it could be a PSW, it could be just another member of the healthcare team with it. Something else that's really important is those daily interprofessional rounds. So when you're connecting with the physician group or you're connecting with the OTs and the PTs, just really having everyone present and having those rounds, it really promotes sort of that patient care, because sometimes, especially when you have some complex patients, you can get some of those things sort of addressed up front. So related to sort of our personal protective equipment, I'm just going to share some of our tips. I'm not going to go into how to don and how to doff specifically, because that's a lot of us are familiar with it, but I'm just going to go through some of the things that we've kind of found that happens related to procedural drift. So just kind of building on what Ruchi said there, most patients only require droplet and contact precautions. So that's the use of the gloves, the gown, appropriate eye protection, and a procedure mask. Where you would want to add an N95 mask is where you have aerosol generating medical procedures. And if possible, the addition of a negative airflow room. And that's kind of interesting because what we actually ended up doing in our unit is we took one of our larger rooms that has 3 beds in it and put a temporary HEPA filter that does the reverse airflow and built an anteroom with it. So we can actually have 4 patients in that room who have aerosol generating medical procedures with it. So some examples at our particular campus or our particular hospital, you have to actually verify with your different hospitals or organizations that you're in or with Ontario Public Health. But some of this common examples that we see here are if we have a patient who has on nasal cannula or an accumulator, when they have a flow rate of greater than 6 liters per minute, then they become aerosol generating. So then we would actually add the N95 mask. Patients who come in with BiPAP or CPAP, that's an aerosol generating medical procedure. Open suctioning of a patient with a tracheostomy is another one. This is not an inclusive list by any means, but it's just kind of an example of some of the common ones that we see on our unit for it. So PPE donning, some of the things that we're sort of finding with this particular one, and one of my roles on our unit is as a PPE champion. So with the PPE champion, I observe all the healthcare professionals on our unit to ensure that they are donning and doffing appropriately to ensure their safety. So one thing that I've kind of found is we need to ensure that we're focused on our task. I'll see some of my healthcare staff, they'll put on the gown and then they'll go and start to prepare some meds, and then they'll put on the face visor and then, oh, they forgot something and they need to go and grab the glucometer. More times you break a procedure, the greater the risk of an error. So really focusing on the task that you need. So when I go around and kind of do some observations and some feedback, one of the things that I share with them is to ensure that PPE is the last thing you do before you go into the room, so that you have all your other stuff prepared first and then don your PPE. A common miss is washing hands before we start. We do wash our hands a lot in healthcare, but before when we go and grab the gowns or the masks or whatever we're putting on, you got to make sure that we wash our hands. With the gowns, it's quite common to forget to have our waist tie done up. And this is important because what you want to do with the waist tie, especially if you're somebody who's on the smaller side or petite, if you're walking around, that gown can actually flap and open up and you can contaminate your clothing or scrubs or whatever you have on underneath. So you want to ensure that waist tie is done up. Also with the gown, you also want to ensure that the cuffs are tucked nice and high inside the gloves. So one of the things that I've done when I've done teaching with it is I don't know if you remember when you're a little kid and you were telling your parents and you would tuck your finger up inside your cuff and you would slide your mitts over top of that. So that's how I've kind of taught that aspect, and it actually works quite well for it. Another common miss is the face visor. A lot of people will put on their face visor almost to the point where it looks like a baseball cap and it's kind of sort of hanging out because they do fog up quite easily. The purpose of the face visor is obviously to protect your eyes, but it's also to cover your mask. So the face visor should be sitting at the eyebrow level and completely cover sort of all the way down for it. When we're taking it off or when we're doffing our PPE, you want to do it in a controlled manner. This is where you have your greatest risk of contaminating yourself. You also want to do it as much as possible about 6 feet away from the bed or the care area for it. Use of a spotter to watch you sort of how you're taking it off really helps so that you don't contaminate yourself. And just kind of build on a little bit what Ruchi was saying there is you want to keep your hands away from your face as much as possible, because as she said, this is passed through mucous membrane, so through your eyes, through your nose, and through your mouth with it. With the gown, when you're taking your gown off, untie the waist strap first, and then sort of go up to the neck. A lot of times, especially when we're in a rush, when we're taking off the gown, we want to just rip it off and throw it into the laundry. In this particular situation, you don't want to do that. You want to do it in a controlled manner, sort of leaning forward to remove the gown, kind of grabbing on from the ties, and sort of leaning forward and rolling the dirty side to the inside, and then rolling it very gently into a ball before you sort of discard it into the garbage if it's a disposable gown, or into the laundry hamper if it is not a disposable gown. Another one is when you're taking off your visor or goggles. A lot of people tend to sort of grab right at the sides here. This is where you're really close to your eyes, with a possibility where you can contaminate yourself. So when you're removing your goggles or your visor, you want to take it off at the back of your head. Also with the visor, because it comes off after you've removed your gown, if you have a very long visor on, you want to ensure that you're not touching your scrubs or your uniform that you have on underneath. So sort of just having your chin up a little bit as you take the visor off. We've got to try and have a little bit of fun with it on the COVID unit to sort of decrease a bit of the stress. So we call it sort of the doffing yoga move, where we sort of tuck our bottoms out and take our chin forward to ensure that we're not contaminating ourselves when we're removing our things. So that's kind of PPE specific components. When we talk about leadership, one thing that really helped a lot, so I'm the educator for our unit, but our unit also has a unit manager and a CCL, or also known as the clinical care manager. At the beginning of our pandemic, we had a daily huddle every single day at about 3 o'clock in the afternoon, because that tended to be sort of the quieter time. And at this point, we use it as an opportunity to do education, to hear about some of the pain points. Especially at the beginning of the pandemic, things were changing almost by the hour. So just as a way of communicating to our staff. And it was just showing our staff that we were there to support them. And that really helped a lot decrease that stress component for it. We did that probably for about 3-4 months until we kind of got into the groove of things. And now that we're kind of split between 2/3 surgery and 1/3 COVID, we do our huddles probably, I'd say 2-3 times a week now for it. But you still require that sort of ongoing support and education for the group, checking in with your staff to ensure that they're doing okay, not just from a professional perspective, but just to ensure that they're okay from a psychological perspective as well for it. Something else that kind of happens up at a bit of a higher level, we have regular interprofessional leadership meetings. And this is where we talk about the unit leadership for each COVID unit, the physicians responsible for the COVID units for that week, and the clinical directors and our patient flow department. We were meeting again sort of at the beginning of the pandemic about 3 times a week, just to ensure that we had good patient flow, to sort of address any other pain points or updates that were coming from the region. And we've kind of decreased that sort of back down to once a week, but still a very valuable meeting that we have to ensure that everybody's sort of on the same page for it. And then to sort of wrap up, just a couple other additional resources that are actually open sourced. The TOH Education Department has a web page that actually has COVID resources for healthcare providers. You can this is a screenshot of the actual web page. The healthcare providers there, the SIM team, we put together about, I want to say, a large group of VR videos that can be viewed by anyone. The patients and families, we've got different resources in there, including a video on how to doff and don PPE for patients and families. And then specifically to long-term care, we've done another one where we have 5 different areas that might help from an education perspective. So if you need some more resources related to COVID, this is an area that you could go with it. And that's all I have for you. So thank you for the opportunity to share my experience.
That's great. Thank you very much, Jennifer. People are a little shy on the chat, so I will ask a question, because some of the people who are viewing today may not have had any experience with COVID. So just as a bit of a high level, there are, of the 18 institutions in our region, about 7 or 8 of them are considered COVID treating hospitals, and the others are not COVID treating hospitals. And even the COVID treating hospitals, really the majority of cases have come through about 3 or 4 of the hospitals. So people may not have had a lot of experience with COVID patients in the first wave. Jennifer, on the floor, what anxieties or what things did you guys or your team feel in March, April, that now with the 6 months of hindsight, you say, you know what, that was okay?
I think it was a lot of around the PPE, and Rushi kind of led to that about the aerosol, when to wear an N95 versus when to wear sort of droplet and contact. And a lot of the literature wasn't out there, and there wasn't a lot of known about it. So it was just that ongoing sort of support and reinforcement from the our team. We also had the IPAC department come up and talk to our staff fairly regularly at the beginning as well. And then just ensuring that all of our staff were fitted for N95 became a priority on our units and at the COVID unit. But it was just that ongoing assurance. There were some concerns sort of at the beginning. We used to call them the Victoria's Secret gowns. They were quite see-through. They were a little bit more paperish. There was a lot of concern around that. So the staff, we said double up with them because there was a shortage at the beginning. But then with working through the unit leadership and our clinical directors, we got a priority switched over to non-disposable gowns. They're almost like a parachute material. That became one of the biggest concerns for the staff. So we addressed it immediately with the paper ones, that we added a plastic apron that was a droplet. That was probably the biggest concern sort of at the beginning. And then when to switch between aerosol versus non-aerosol. All right.
Yeah, that makes a lot of sense. And Rushi, from a clinical perspective, you know, what did you hear that was a real concern to the clinicians and the nurses on the floor? And how has that sort of changed now with the second wave coming up?
It seems as if the paranoia sort of lulled, if you will. And I think a lot of that's coming from people now having potentially had patients with COVID. Before it was a lot of unknown. And now it seems as if that people have some experience under their belts. And also the practicalities of it all. I think public health has been really helpful in certain ways supporting IPAC. Just for an example, if there's an exposure and someone's not wearing a gown and glove, what does that mean in the big picture? And the truth is that mostly everyone in the hospital is wearing a mask. It's mandated for healthcare workers to be wearing masks with visors. And so I think that reassurance of having that on all the time is very helpful. Plus the reassurance for troubleshooting a case where you've been exposed and you may not have that gown and glove on, but you can say, okay, but at least I had my mask, at least I had my visor, and occupational health, infection prevention control, and public health all being on the same page that it's okay. Things are going to happen. We're going to have people show up in hospital or in any facility across the city and not know what their status is. But that's why we're doing these basic precautions to protect us. And in a way that also translates to the community at large. That's why we're encouraging masking outside of the hospital as well, for what that's worth. But yeah, I think it's the comfort level that's very different from what it sounded like way back when compared to now.
And related to that, there's a question in the chat about the healthcare team that you had on the wards. You know, would you advise a consistent team on the wards to develop an expertise? And if so, because frankly speaking, that's what happened at the Queensway. Mm-hmm. You know, what would you think about that with respect to the nursing and the allied health supports? And what are some of the challenges of being in COVID day in, day out?
Do you want to go ahead, Jen?
Yeah. Definitely having a dedicated team because we're sort of I'm going to call a split unit. We also have a float team here at the Ottawa Hospital, but we don't put the float nurses, the surgery resource team, we don't put them in the COVID unit because they don't have that consistency to maintain the competency related to PPE donning and doffing. Especially in the beginning when there was a lot of uncertainty, we had a dedicated medicine team for each unit. For the COVID side, because most of them were medicine patients. Now we're seeing a bit of a mix. We're getting some surgery patients, we're getting some medicine patients. But I have noticed, because we've done discharge rounds at the Ottawa Hospital for all surgery patients that are inpatient units and medicine patient units for numerous years. But we have our surgery resident present, but we also have the medicine resident present as well for those rounds, just to provide sort of that consistency of care. But I think it's a bit more of a challenge now because we do have that mixed population as opposed to like it was more of a medicine population, and maintaining that consistency. Try to make an effort to connect with whoever's new coming into the unit for staff, but sometimes that doesn't happen. So there's a bit of relying on the healthcare staff to ensure that if we have a new resident coming in or a new RT, to ensure that they're wearing their PPE properly.
Yeah.
Okay.
Yeah. And I think to add to that, I think the question that this person is asking about the challenges of maintaining that consistent team. I know at the Queensway, that's what our team had done. We had 5 ID docs that happened to be at our hospital, so we were able to have the manpower to do that. And now it's kind of a matter of efficiency and preventing burnout on many different levels. And so I think the expertise is shared. It's a shared experience. And so all of us are giving our anecdotal experiences and sharing that with one another, so that you're not just dependent on one person or a select few. We're all learning a little bit so that we can be best prepared, and we're learning the key messages, and that speaks to efficiency on so many levels. And so I think that's what's probably different as well.
Yeah, kind of just to add a little bit to what you're talking about there, Rushi, burnout, I think, is a big one when you're talking about sort of the daily care of our patients. Because like on the COVID unit, we have COVID positive and COVID suspect, and when we have a COVID suspect patient, as soon as they come back negative and they're removed from the COVID status by our IPAC department, they're sent to a different area in the hospital. So the turnaround in the COVID unit can be as high as 75 to 80% on our particular unit. So that's taxing from a nursing perspective and an allied, because you go through admission and you go through discharge. So one of the things we've done from a staffing perspective is we ensure that our nursing staff that are in the unit are a maximum 2 shifts in there in a row. So they'll do either 2 days or 2 nights, just to prevent a bit of that burnout for it.
Interesting. And I guess on a related question to that is, you walk around, and at least for the last part of the summer and early part of the fall, there was a lot of COVID fatigue. The heightened sense may be building with the numbers increasing in the community. And I suspect that COVID fatigue was building in the hospital itself, people being a little bit lax. How do you battle that, especially now when we need to be as vigilant as possible?
You know what? I think it's just on maintaining an ongoing presence, checking in with the staff. I still do those like PPE, call the PPE observations. I'm there with my iPad, taking data and sending it to IPAC and kind of framing that more as an observation as opposed to an audit. Just doing it consistently and being present and making that conscious effort to do it, and know that the staff are there, because as with anything, we see the drift related to COVID fatigue or anything, not even just COVID, life in general. So it's just that constant presence, I think.
Yeah. And I think also what you're doing is great, checking in on your colleagues and recognizing those early stages of burnout, because I'm sure we're all susceptible to it at some stage or another. And, stepping up when you can, stepping back when you need to, and making sure that you have that backup system available to you, as well as the support through Zoom, I guess, of family and friends. But keeping your mental health in check is so important.
Absolutely.
Yeah, that comment on keeping in touch with your family and friends is a nice segue to the next question, which, in our experience at the Queensway, one of the things that may have surprised us is the isolation for patients. So people who haven't dealt with a lot of COVID patients, if they do start to filter down to some of the community hospitals, these patients are in isolation. Visitor policies were very restrictive at the first phase, a little liberalized now, but who knows, may become more restrictive going forward. And it was very challenging for these patients who were sick, sometimes who were elderly, maybe some dementia, to even recognize that they had a care provider, where they were, and no connections with their regular touch points. How did you guys deal with that? Or do you have any recommendations for how some of the centers who may be coming up with these issues to deal with this going forward?
Yeah, I can speak to this on 2 levels. As a patient and as a physician, I delivered a baby in the pandemic. And so I was also in isolation and laboring alone for a good part of my personal experience. And I have to say, although FaceTime and screens are great, there's nothing like the human connection. And so having a fresh healthcare provider at the bedside made that experience, and who was kind and could just agree with you that yes, this is hard, this is tough, this is scary. That acknowledgement of your experience was what made that experience for me personally survivable and pleasant. And as a healthcare provider, I have noticed anecdotally, speaking to some of our elderly patients who've been in isolation with COVID, taking the extra 2 minutes just to have a normal conversation, it changes their tone, it changes their whole afternoon. And I think we take that for granted. Yes, we have iPads, yes, we have screens, yes, we should utilize the technology, but I think from people of a certain vintage, that doesn't quite cut it. And so I do think that it's important to keep humanity in check.
Yeah, I couldn't agree more, Rishi. We had iPads that we set up to do the sort of the virtual visits, but just taking that time to get down to the patient level and acknowledge them as an individual. And that's hard when you got the PPE on and all you see is this yellow person all dressed in kind of yellow and a mask all on. Some of the staff were taking stickers and sort of putting their names on their PPE so that at least they knew the patient's name or the healthcare provider's name, and just taking that extra time. And that adds to it. But it's doable. It's just being conscious of it.
Absolutely.
Great. Excuse me. Okay. Well, with that, we're coming up at 12:45, which is the end of lunch for most people, if it hasn't already happened. So I want to thank both of you for a very excellent and informative discussion today. As a reminder to the audience that this is being recorded and will be up on the website. I don't have the website details in front of me, in the next week or so, and we will send an email out broadly so people can access it at their own leisure. Again, thank you very much, and thank you everybody for attending today's.
Thank you for the opportunity.
Thank you. Bye, everyone.
Bye.